Hi, everyone. My name is Dr. Everard Harris. Thank you so much for joining this presentation today on ADHD. So this presentation is for GPs, and so as a result, I'll tailor the information for you guys and you all. Okay. So just to let you know about myself, I'm a forensic psychiatry by background. I've trained in the UK and then worked over in Victoria as a forensic psychiatrist in the prison system and at Thomas Embling Hospital. The reason why I um, like talking about ADHD is because I see lots of people in all walks of life who have ADHD. So I see super successful people, doctors, lawyers, lots of entrepreneurs, lots of people in the trades who are super successful with ADHD, but I also see lots of primarily men in the prison system with ADHD. And that's always intrigued me, how a condition could present so interestingly with super successful people and people who are not doing so well. One of the questions that GP do ask is, what do you need to actually start the medications? For example, what tests do you need? What investigations do you need? In my clinical practice, I tend to have routine blood tests and an ECG. So the routine blood tests usually are FBC, using these TFTs, LFTs. I often look for vitamin D, B12, and magnesium. What I've found in my practice is that sometimes you can pick up patients who have those abnormalities, and those can impact on their attention, focus, and concentration. And getting those treated as part of GP practice can often have a meaningful improvement in their attention, focus, and general health. So what I would normally do is when I've send my letter to a GP is I request those tests. And quite not very often, but a few times we've picked up some cardiac abnormalities which would have been detrimental if the ECG wasn't done. In terms of the common phrase you can hear from certain generations is that ADHD is a fad, and in some ways I completely understand it, because with the advent of TikTok, X, and Instagram, there's a lot more patients coming through recognizing that they might have ADHD, and are more likely to ask about getting diagnosed. So just to give you some context, in terms of ADHD, something that I've always been intrigued by as a psychiatrist. So I've worked in forensic neurodevelopmental hospital in the UK, and it was the first time I saw that the impact of ADHD and ASD on people's presentation, but also on the crimes that they've committed and the impact that they have on their lives, their ability to function, and also their loved ones. So I've always been intrigued in terms of how we could identify these individuals who often present in a much more complicated way. So they often present with substance use issues. They often present with gambling issues. Sometimes they may even present as antisocial. And quite often, as I've alluded to before, you have these people who are patients who are quite difficult to manage. But then you have individuals who are super successful with ADHD. And as a forensic psychiatrist, the patients with ADHD that I see are often quite complicated because they have a whole range of other um, complex social structures around them. Um, complex social structures around them. Okay. So, in terms of stimulants, I think the primary focus of this session today is about commencing stimulants, because more than likely that's what you'll be commencing as a GP. The reason why that is that stimulants actually do work. They absolutely transform the the im- the presentations that you see. My patients are better able to function on stimulants, and also better able to engage in the therapy that they need. So, for example, I could give you from the severe end, where I've had patients who have been getting in trouble even within the prison system on strict management regime, which, as part of my assessment, I've identified that they have ADHD. And with the treatment of stimulants, their behaviors absolutely have transformed, where they're able to listen to the officers, follow the rules, not thrill seek. They're much better in terms of being much more polite, and have actually transformed them to the point that they have gone from 23-hour lockdown to being out and about in the community. On the other end, I also see um, men who are on the surface super successful, women who are super successful on the surface also. And what happens is that they're often masking. And what I mean by that is that they spend a lot of mental energy, lots of systems to actually stay on top of what they're achieving. And that can be quite fatiguing. Eventually what happens if they'll be, as the saying go, the straw that broke the camel's back, where something outside of the routine causes them to have a major breakdown. And quite often they present to GP and with anxiety, depression. And eventually, if I do see patients like this, then what I do identify is that they have ADHD, have a major burnout, and present in a way that can be quite difficult to identify. Um, One of the questions I've had was about the cardiovascular assessment, what's needed. Okay. So a large study in 2011, Cooper et al. Look at young patients and young adults with who were due to be started on stimulants. And what it found is that there was no increased cardiovascular events associated with ADHD medication. The reason why this is important is that if there's a cardiac event that happens, it's likely to be as a result of some other and underlying cardiac issue. It's still really useful to do the ECG, so we have one on the baseline, so that in the future, then we know that we could categorically say that whatever arises is not as a result of ADHD medication. In addition, another study by Habel et al. In 2011 found that there were no increased cardiovascular events associated with ADHD medication. From a practice and a clinical point of view, what I often say to my patients is that it can increase your heart rate. So you might actually notice that your heart's going a little bit quicker because it can stimulate the sympathetic nervous system. But that should settle down. And I'll often say that, remind them that it can increase their blood pressure. So if you do have high blood pressure already, it's really important that you are aware of that. It doesn't cause an increase in MIs or strokes or anything as serious as that. The other thing that patients might notice is an increased heart rate, increased likelihood of headaches. Uh, but if you actually start the stimulant at a much lower dose, which the most commonly used stimulant I use is Vyvanse or lisdexamfetamine, I normally start at 20 milligrams for 2 weeks and increase it to 30 milligrams. And I found that by doing that, there's a significantly less likelihood that patients complain about these side effects. In the past, I would used to start on 30 milligrams or 40 milligrams, and quite often it was too intense and too high a dose for patients. And so um, that new regime seemed to be much better tolerated. Which stimulant do I pick first? And that's a really good question. I base that on a number of things. Okay. So, for example, quite often I would say about 80 to 90% of my patients are on Vyvanse. And these are for patients who often work full-time jobs and therefore need a longer coverage of being able to pay attention, focus, and to be organized. And Vyvanse is great because it has a reduced likelihood of lasting into the evening, so it impacts on my patient's sleep. Because in addition to all the other issues associated with ADHD, sleep is often a common factor and an issue that they often complain to me about or report to me. In terms of Vyvanse, I've found it to have a better, the doses go up in increments of 10, so 20, 30, 40, 50, 60, 70, which is actually quite handy in terms of finding the right dose and dose titration. This is much more gradual compared to Ritalin long acting, which seems to have bigger drums. There are a proportion of patients who are not working, or they're retired, or they spend lots of the time at home and don't want to, or don't need to have that level of focus. And quite often, I would then prescribe them a short acting, either dexamphetamine or short acting methylphenidate. In most of those instances, Vyvanse seems to work the best. However, there's a small cohort of patients who, for some reason, do not tolerate Vyvanse. Often it's seen as too intense. And I've swapped over to methylphenidate, short acting and then long acting, and they seem to tolerate that much better. In addition, Vyvanse seems to have less appetite suppressant effects compared to methylphenidate. And patients in general tell me that Vyvanse seems to be less buzzy. So they don't get that on edge feeling that they can sometimes report with methylphenidate. Just to assure you, I'm not getting any paid promotions or shares. I don't have shares in Vyvanse or lisdexamfetamine. So this is all from my clinical experience doing the research and working it out. The next question is about safe clinical prescribing. It's the standard that we always talk about, which is to start low and go slow, which usually works great for my patients. But there's also a level of impulsivity associated with my patients with ADHD wanting to go up quickly. What I have to remind them is that with each dose increase, there's a possibility that that dose becomes too intense and too soon, and actually you may get side effects which stops you from going up further. So in general, for the first 2 weeks, it's 20 milligrams and 30 milligrams if it's Vyvanse. And then between every 4 to 6 weeks, then they may go up to by 10 milligrams. In my clinical practice, where it's clear that these men or women have been using other substances in the past and their tolerance for a stimulant is much higher, occasionally I may increase it sooner depending on the situation. But in general, it's by 10 milligrams, and that is what the recommendations are. What are the common side effects of stimulants? The evidence shows that insomnia or sleep disturbance is quite it can be quite common, and that's especially if they happen to take it too late. Often I tell them to take it between 6, 7, 8 o'clock, and often encourage them to have some food before. Often encourage them to have something that's protein rich. So I may say have one of those up and go protein drinks. Often have 17 grams of protein, which is quite high, and that's much more tolerable than having a massive English breakfast. And also, quite commonly, lots of my patients do intermittent fast. So the idea of breaking their routine from fasting in the morning seems much more tolerable if you recommend a protein shake. So the other question that I was asked is, what's the psychiatric risk? What to watch for and what to do? So interestingly, from a psychiatric point of view, in the past, I used to be much more worried about the stimulants causing psychosis. If you start at low dose and gradually increase it, then that's highly unlikely to happen. In addition, in the past, we used to say patients who are psychotic shouldn't have ADHD medication or stimulant medication. Over the past 5 years, I've treated patients with schizophrenia who also have ADHD with stimulants, and it's actually helped in terms of their impulsivity. It's helped in terms of their mood. It really slows down some of the negative thoughts that they have. So it's not a hard indication. But what I would say to you as a GP is, then that's really something that psychiatrists should be managing. And I would be probably reluctant to be managing all those yourself without some psychiatric input. And that's also, there are some of my colleagues who don't work with ADHD or in such complex inpatient settings who would not also feel comfortable managing. So it's not just a GP thing. So, monitoring plan, I'll slide it. So, what to track? So, first thing that often happens is that patients would notice an improvement in their attention and focus, but their partners also recognize it as an improvement. What they often recognize is that, oh, you're listening to me. And so when their partners are talking to them, male or female, with ADHD, it's quite easy for them to be distracted by thoughts in their own heads or noises that are outside or something that goes by. And partners often pick up on this. And so what they would report is that, oh, my partner says that I'm listening now. I'm much better able to communicate. The other thing is that they complete simple tasks. So instead of starting 10 different housework things, they would actually finish a task and then move on to the next one. And one of the things that patients say they like and love about the medication is that their brain just feels empty. And for some people that might seem alien, but if you have 1,000 thoughts or 100 thoughts going through your head, the thought of just having one thought at a time can actually provide a real sense of zen for patients. In terms of safeguarding against misuse, interestingly, I think in the past, there was a real big concern about patients misusing their stimulant medication. That does happen. I'm not naive to that. But quite often, with the benefits that they do experience, patients are highly unlikely to be actively trying to sell their medications. What I would normally do is you could normally tell if they're misusing it if they are applying for scripts much sooner than you would expect. So I would put a minimum time between when their full scripts would be able to be filled. So if they're filling their 30-day scripts in 15 days, then there's something that's going on there that needs to be discussed. And that could be for a number of different reasons. Instead of just stopping the medication, I often use it as a means of understanding what's going on, so that they're better able to manage. It could be as simple as that they've just been so disorganized that they've left their medication somewhere and they can't get it, so they need to get it prescripted. So shared care in Australia. So GPs are at the front line in terms of shared care and managing ADHD, hence why we're doing this CPD. Often, it's safe if you go from 20 to 30 milligrams, as I've said. But once patients are stable on their stable dose, then if every year you do a blood test and ECG just to be sure that nothing else is going on, uh, make a referral to psychology, especially a psychologist that has knowledge of neurodevelopmental conditions and maybe trauma, maybe in terms of, say, fit the self-esteem, because ADHD doesn't just impact on attention, focus, and concentration. Many more patients, because of making mistakes in life, going through different, as simple as being told that you can't learn or that you're silly or you're stupid, these things actually can be quite internalized and will be, better supported with psychology and not just medication. I think that's it. Thank you so much for listening. I hope it has been helpful and look forward to hearing your questions and maybe doing it again. So thank you.